Hi, I am Maurizio Taramasso. I am associate editor of JACC case report for the domain of structural heart intervention and cardiovascular surgery. And I have the pleasure to be here with Dr. Brinder Kanda to discuss one really interesting educative case, which is gonna be presented at the next American Heart Association with simultaneous publication of our journal that has been selected because it's of particular interest for our reader. So why don't you introduce to the readers and to the listener your cases, and you tell us a bit more what's your case about it.
Yeah. Thank you, Maurizio. I'm Brinder Kanda, one of the interventionalists in Richmond, Virginia. So we had a unique case that presented diagnostic and therapeutic challenges. We had an 83-year-old, very pleasant patient who had a known history of hypertrophic obstructive cardiomyopathy, who declined intervention in the past with stable symptoms for many years, followed by a local cardiology group. She also has COPD. She presented to emergency room with acute decompensated heart failure. She was hypoxic, borderline hypotensive. Initial cardiology receiving team stabilizer obtained an echocardiogram that was very difficult because she has LVOT gradient, also thickened aortic valve and septal anterior motion. So patient was admitted to her ICU for further evaluation. We obtained a TEE because it's not clear, is it a LVOT driven heart failure or there's something on the valve. It was very difficult to see, and also to assess the degree of aortic stenosis. Transesophageal echocardiogram did show that she has at least moderate aortic stenosis with planimeter valve area about 1. That was 0.6 centimeter per meter square, so in the moderate range. But she has a large flail segment that was not present in her previous echoes, that was new. She has significant LVOT gradient. So we did invasive hemodynamics to confirm that. It was a beautiful hemodynamics showing LV apex to LVOT gradient about 90 millimeter of mercury, and LVOT to aortic valve gradient only 10 millimeter of mercury. Our hypothesis was patient was getting older and had a fibroelastic deficiency of her chordae and couldn't do SAM anymore and ruptured the chordae and developed subacute to acute mitral regurgitation. This also tells the importance of the heart team, how to deal with this difficult patient with a moderate aortic stenosis, SAM, hypertrophic obstructive cardiomyopathy. Due to her advanced age and she did not want to pursue any surgical intervention, the heart team, we presented an option to proceed with a TEER, transcatheter edge-to-edge repair therapy with the Abbott device, MitraClip. Patient underwent MitraClip XTW time 1. We captured the flail segment successfully and had a mild mitral regurgitation with the diastolic mitral gradient about 5 to 6 millimeter of mercury, depending upon the heart rate. We did also repeat the invasive hemodynamics after the clip deployment, and her gradient from apex to LVOT was practically gone. She did very well. She was extubated the same day and went home next day. And on the follow-up echo, her LVOT gradient was in 20s. She's still doing well. She has a minimal mitral regurgitation and been stable since then. We also had a plan to do alcohol septal ablation if her gradient seems to be higher post-TEER or transcatheter edge-to-edge repair. But because the invasive hemodynamics showed us the gradient was in 20s, we did not pursue that, and she did clinically well. And I think that was probably the right decision. The challenge in this case was number one, diagnostic. What is contributing to her symptom? Is it, aortic valve, is LVOT gradient, or this is subacute mitral regurgitation that we end up treating. And this also delineate the importance of the heart team, that surgeons, interventionalists, non-invasive cardiologists, cardiac anesthesiologists, all involved decision-making process.
Yeah, that's a great case and a really good example of how complex situation can eventually be treated with a simple solution, thinking a bit out of the box, I would say. Obviously, the challenge was diagnostic, probably the most one, in order to identify the culprit problem. And this was treated in a brilliant way. I would like to ask you, beside the challenging in diagnosis, did you encounter any technical challenge during the procedure? Was it a straightforward mitral clip procedure, or was it complex? I don't know, maybe sometime in such a case, the left atrium may be small or whatever. How was your strategy? Why did you select XTW, and which technical and anatomical challenges did you find as compared to a normal procedure, if any?
Oh, yeah, excellent. Yes. So the technical challenges were following. One, she has a larger flail segment. Second, her hyperdynamic left ventricle. So they posed both challenge. So I actually had a plan to, if we had a rapid pace, to kind of stun the LV a little bit to drop the flail segment, but we didn't have to. We oriented the clip above the valve and actually went on 3D, make sure it doesn't rotate, and just barely went under the zone of coaptation of mitral valve and dropped the grippers. There was a lot of motion when, if you go deep in the HOCM patient, they can pose a challenge. But as long as you are very diligent, stay very close and under the valve plane, I think usually it turned out to be okay.
I think this is one of a more common example of, let's say, off-label use of mitral TEER. There are some other occasions like acute mitral regurgitation, for example, or for example, is emerging more and more atrially driven functional mitral regurgitation, which is an untypical indication. How do you see the use of mitral TEER overall in the treatment of patients with heart failure?
So I think the heart team approach is more important than it's been ever. In TAVRs we kind of streamlined it. That's how it started. But in mitral cases and tricuspid cases, I think it's very, very challenging, especially as human atrial functional mitral regurgitation. We also have our EP colleagues come to those meetings as well to say, hey, maybe we should optimize the AFib and left atrium. So I think it's becoming more complex and challenging. On the other hand, it's also more subspecialties involved. So decision making is not one person or two persons, a whole team approach. And our surgeons are also very involved because they do hybrid ablations and optimizing these functional MRs especially. Now, this patient, there's small series published with the HOCM patient for the transcatheter agitoid therapy, with some success, but it's not mainstream, obviously. I do alcoseptal ablation and now mavacamten as well for HOCM patients. But this was a very off example where you have a Flail, Leaflet, and a HOCM and some aortic stenosis. So we had to come along. Everybody had to contribute to see what is the best course of action and plan A, B, and C.
Yeah. Last question. What's your take-home message for our readers? And before ending, thank you again for submitting your cases to JACC case report. It's really educative, and I think the readers will enjoy a lot.
Oh, thank you. My pleasure. So I think take-home message number one is structural world is evolving, so a lot of out-of-the-box thinking. Everybody's contributing now. So number one, including patient and their family, need to be involved in decision making because we're doing all this out of the box, off-label procedure. They need to know what's unknown about it. Second is mitral clip or TEER-like therapy is very possible in HOCM patient that's shown in small series and in our case as well, as long as we have experienced centers and well-formed heart teams. And the heart failure physicians need to be sit in the heart team meetings as well. They can't be going away from us. It can't be only surgeons and ICs. So I think the whole team approach and understanding the technical challenges beforehand is a way to go.
Thank you a lot for sharing with us your cases, and hope you will, and all the participants to this video will enjoy American Heart Association and will enjoy also your cases and other similar cases on our JACC case report journal. Thank you.
Thank you, Maurizio. Appreciate it.